Hey everyone, so welcome to the Tumor Talkers. This is a heme-onc interest group that we initiated this year, and we plan on bringing different kinds of activities, different kinds of lectures to all of you. Today, the topic, I don't want to reveal it as of yet. I have two case scenarios that I'll be presenting before I come to the main topic, so we can have more active participation from everyone as well. So let's begin. So this is a patient that I've actually seen at my ICU rotation this year. This is an 85-year-old male with a history of hypertension, hyperlipidemia, diabetes. Came in with acute hypoxic respiratory failure. He was saturating 88% on a non-rebreather. So he was pretty much COVID positive. That's why he was admitted. He was initiated on the MAT Plus protocol for COVID, which consists of IV methylprednisolone, and you have remdesivir, you have vitamin C, thiamine, and full-dose Lovenox. So this patient, eventually he declined. He was put on a BiPAP, and then later his hemoglobin and platelets started to downtrend. And on day 5 of admission, his platelets decreased from 109 to 109 with a hemoglobin of 6.5. His initial platelets were 299 when he came in. So later, the patient desaturated further, and then he was eventually intubated. And while we were trying to intubate him, there was this pretty large-sized clot that initially was found. I mean, we were kind of past the ET tube, and no one could. And then the attending went in, and he actually noticed something was obstructing the ET tube. He put in his hand and literally scooped out this big clot that came out. And afterwards, the patient was intubated, he coded. Unfortunately, he didn't make it. But while we coded him, he had these secretions, like dark clear secretions coming out of his mouth as well, and through the ET tube as well. So what do you guys think is striking in this particular patient? Anyone?
Needing a huge drop in platelet counts.
Okay.
Clot.
Clot. So yes, the clot and the secretions while coding, and a drop in the platelet count from 299 to 109. What do you think is going on in this patient? If you would have to say, what are all the differentials you would think in mind at that time? Mm-hmm.
But also you would have to think about just any kind of blunt trauma when they put in the ET2 if he's bleeding. It has a lot of faults there.
So as you said, we got all these labs. We got a head panel. We held his anticoagulants. And this was what we found.
How long did it take to the panel to come back?
It took 2 days to come back. So all you guys were right. So pretty much we have to rule out DIC and any other causes of thrombocytopenia and not just go based off of just the hit panel alone when we have to diagnose this. And I have another case here. So this patient, a 55-year-old with a history of hypertension, hyperlipidemia, Hep C, AFib on Eliquis, admitted for nausea, vomiting, diarrhea. Pretty much eventually she got a catheter placed for fluid resuscitations, and she went into the ICU. She was treated for septic shock secondary to UTI. And then after 7 days in the ICU, she came back to the floor. A day after, she started developing this kind of necrosis in her fingers. And then we noticed a platelet count, which dropped from 200 to 90. Hemoglobin was stable. Normal repeat septic workup. DIC panel was normal. No other abnormalities on the peripheral smear either. Pulses were intact, but we got an ultrasound which showed a microvasculature thrombi noted. And patient remains hemodynamically stable. I know you guys know that this is HIT, but I want to ask you, why do you think this patient developed it? This patient just... Eliquis? Eliquis shouldn't cause HIT.
It flushes. It flushes causes.
So this patient central line maintenance, we give heparin flushes. Even though it's a very low dose, it can also still cause HIT.
How many did she give?
I'm sorry?
How many heparin flushes?
Since the day of admission for her central line every day. Yeah.
Twice a day.
Most of the times they don't document that.
Yeah.
They don't.
There's nothing documented about it.
And one thing we have to remember in these patients is that not just stopping their anticoagulants and treating them, but remove those catheters as well, because they still have that heparin lined towards in the catheters. Just remove all the catheters in these patients. So this is our first topic. So it's gonna be on HIT, heparin-induced thrombocytopenia. So basically this is a pretty funny, I guess, little picture, but what it is you have heparin, which binds to these platelet 4, factor 4, which is something that's released from activated platelets. And once this complex is formed, you have these IgG antibodies, which sort of form these immune complexes, as you can see right here. And these immune complexes will go through the Fc receptor, attach to the platelets, and once they're attached to the platelets, you have activation and aggregation. And this can lead to a couple things. One, this activation will again cause this, and the cycle repeats. 2, it causes destruction, thrombocytopenia. It causes aggregation of these platelets, ultimately lead to thrombosis as well. And this is the basic pathophysiology of heparin-induced thrombocytopenia. So let me just give you a brief history. You know, this is first discovered or detected back in the 1950s. And at that time, what we just had like a test to measure the IgG antibodies, which were found on platelets when there's heparin, but we never really knew is this heparin or anything that's causing this. It was back in 1992. That's when the first study that was published, which said what was a target for this particular disease. And that happens to be the platelet factor 4 that we know today, right now. So what are some risk factors? And honestly speaking, the incidence is very low. It's like 0.2 to 5%. But I have seen 2 cases myself here in my first year. So anything is possible here in Shreveport. We see a lot of rare diseases. And this is something to just keep in mind. So you have 2 different kinds of risk factors, I would say. 1 is the type of heparin related. 2, you have the host related. So the heparin related is 1, what is the type of heparin? The unfractionated heparin is known to cause it more than low molecular weight heparin. And 2, the duration of therapy. If it's longer the duration, the more risk of you developing this. However, I want you to remember all the studies that have actually detected this or determined this were on surgical patients, not medicine patients. So the key point here that I want you to take away is that in medicine patients, the studies actually did not show any particular significance towards one particular type of heparin. It's more in surgical patients that it has. So it can be even with like our heparin flushes, low molecular weight heparins, low venoxes, anything could cause this as well. And coming to host-related risk factors, it is more common in the middle-aged and elderly, and it's also comparatively more common in females than males. And then what are the different kinds of HIT? As we all know, there are 2 types, type 1 and type 2. Type 1 is the less serious one, whereas type 2 is the more serious one, which is also known as heparin-induced thrombotic thrombocytopenia. That's because this is where you see the thrombosis in this type 2. So type 1 is usually more common. It's 10 to 20%, whereas type 2 is actually very rare, 1 to 3%. But both the cases that I have seen are type 2 here that I presented. And in type 1, it usually occurs within the first day to 4 days, whereas type 2 is where you have, after 5 days, that significant drop in platelet count. Usually it's type 2 where you have that more than 50% and even the platelet count going as low as 20,000. And the type 2 is the one which is antibody mediated. As I said, the thrombosis is seen in the type 2 here. And usually type 1, since it's not as severe, we don't really manage it, whereas type 2 is where we actually stop the heparin and then give other alternative products instead. And what are some other kinds of heparin-induced thrombocytopenias that we see? You have something called delayed onset HIT. What this is basically once you stop using this product, this is when the HIT starts happening or it gets worsened. which is usually rare, but these are just some to keep in mind. Another is refractory HIT. What is refractory HIT? You continue to have thrombocytopenia despite you stopping your heparin for more than 1 week. And then you have spontaneous HIT. This is, you don't need to have like a recent exposure to heparin. Maybe it might be a couple months ago, but now you have these antibodies present. That is spontaneous HIT. And then you have heparin flush, as I pointed out, for central lines or any other lines that we use. Very rarely, I haven't really heard much or seen much, is the fondaparinix associated HIT. I guess that can also trigger it sometimes. And then you have the severe HIT with DIC. How do you know that this patient is severe HIT and DIC? Your DIC labs, your fibrinogen will be low, and your D-dimer will be high, and you'll see schistocytes on your peripheral smears. That's how you know this patient has HIT, as well as the DIC as well, which is a very serious phenomenon. And then what are the different phases of HIT? One is starting stage is suspected HIT. You know these platelet counts have dropped, and you have HIT in your mind. At that time, you still don't have your antibody testing done, or it's not available as of yet. And then you have acute HIT, where you actually confirm it. How do you do that? You get your HIT panels, and you have the positive HIT panel. And then there's something called subacute HIT, which is of 2 types. You have type A and type 2, or B, sorry. So in type A, what this is pretty much you have your antibodies positive, but the platelet counts come back to their baseline and back to normal. Whereas type B is similar, but you have something called functional assays, which I'll be going on in details later on, which are actually more the confirmation test for HIT. Our antibody tests are usually just a screening test. In cases where your screening test is positive, but your functional confirmation test becomes negative, that is considered a subacute HIT type B. And then you have remote HIT. Remote HIT is pretty much you had HIT, it's resolved, you don't have the antibodies anymore, your platelets are back to normal. However, these patients are at a higher risk of developing HIT later on in their life once again. So what are some approaches for diagnosing HIT? So as we speak, definitely look into the platelet counts, either more than 50%, or in some cases, they can only fall by 30 to 50%. 2, look at the duration, 5 to 14 days. Sometimes in patients, like I said earlier, who have already had HIT in the past, and we don't recognize that and we start them, you can have these drops within the next day itself. That's something to be aware of. Another thing is platelet counts. They can go as low as 20,000 as well. Check for thrombosis. They can be venous, they can be arterial. And another thing is you don't really have the thrombocytopenia manifestations in terms of petechiae or purpura or these kind of mucosal bleeds. These are either mainly thrombosis. Bleeding is actually rare in HIT compared to its thrombosis, that's mainly. Another thing you have to do is rule out any other possible causes. DIC, unless DIC is associated with HIT. Rule out infections, rule out any other causes of thrombocytopenia. So then there are some scoring systems which have been developed, and one of the main scoring systems that we use is called the 4T score. So what does it consist? You have thrombocytopenia, you have the timing of when the platelet counts fall, then you have thrombosis, and then you have the reasons for the thrombocytopenia. So for the thrombocytopenia, it's pretty much the same thing we discussed. Check the counts, check the percentage that they dropped. If it's more than 50% that they dropped, or around that 20,000 range, 2 points. If it's much lower or lower percentage dropped, you have lesser points. And then the timing, again, the 5 to 10 days, or if they have previous exposure less than 1 day, or if it's greater than that, the points keep dropping. Then thrombosis, check if you have any new thrombosis, or you may have recurrent thrombosis or worsening of the previous thrombosis, which gives a lesser point than that. And make sure you rule out other causes for thrombocytopenia as well. Once you calculate the score, at the bottom, as you see, you have 0 to 3, 4 to 5, 6 to 8. 0 to 3 is low probability, 4 to 5 is intermediate probability, 6 to 8 is high probability. It's usually the intermediate probability and high probability are the ones that we consider actually testing for HIT. If it is a low probability, we stop right there and we don't pursue further. And coming to this 4T scores, how did this come into picture? So there have been some studies where they have actually validated the these scores prospectively. And one study that I came across was done in Canada, where they have checked different patients, and they checked different patients in different categories. How many were low probability, how many were intermediate, how many were high probability, and how many tested positive for HIT based off of the scoring system. So among the low probability, only 0.9% tested positive, intermediate probability 11 to 4% tested positive, whereas coming to high probability, 34% have tested positive. So based off of these, they've come to determine that this is something that is useful, but there are other models out there as well. There's something called Lilo-Lei-Lue model. I don't know if I said it right, but this is something that's used in bypass surgery patients in particular, because they also take into duration not just the duration of thrombocytopenia, but also the duration of the surgery procedure as well. And then you have something called the HIT expert probability score, which is similar to the 4T score. However, in this, what they do is if there is bleeding or if there is any other cause of thrombocytopenia that they have detected, they'll just subtract in the score. But usually, according to the 2018 ASH guidelines for HIT, what everyone recommends right now is to actually using the 4T score system in our approach for diagnosis of HIT. So what are the tests that are actually available? You have the immunological test, and then you have the functional test, as I mentioned before. The immunological tests are the ones that we usually get, the HIT panel, which measures the antibodies of the heparin and the platelet for combinations. And look at, if you notice, this particular test that we get, the sensitivity is like more than 95%, but look at the specificity. It's like 50 to 89%. So we can pretty much rule it out, but the confirmation because of this is actually significantly lower. And that's where your functional tests come into picture. These tests have both higher sensitivity and higher specificity as well. Another thing you have to remember is these functional assays, they detect the antibodies that actually induce a heparin-dependent platelet activation. Whereas these immunological tests, they detect these antibodies. However, they detect them whether they're there or not there, but not if that exact thing is producing this kind of activation in that patient or not. So look at the immunoassays. One problem is the turnaround time. Sometimes they take longer. In our patient, it takes 2 days, sometimes even longer. And another thing is their poor positive predictive value. So what happens? Sometimes we stop over there. So we end up treating every patient as if it's a serious HIT every time we start looking at that being positive. Because of that, we had a lot of misdiagnosis, and we also have a lot of unnecessary treatments that we do. There are some other immunological assays that have come into picture. You have the rapid fluid ones, which come in minutes. There's some particle gel immunoassays that have been studied. However, all these still, their trials are going on, the testings are going on. There is no particular study which proves their usage and how valuable they are. And the functional testings, these are the serotonin release assays and the heparin-induced platelet activation assays. They are more specific. However, the problem is not every area does this, not every testing center does this. There are fewer testing centers because they require more, technically you need more to do these kind of procedures. So because of this, another problem with these is that the standardization. Not every area has their own set rules of what is positive, what is negative. So they're not globally standardized either. That's the reason we don't see these tests, even though they're highly sensitive and specific, be done commonly. So this is the overall diagnostic approach from the 2018 guidelines for HIT. So you have the patient, you're suspecting HIT, their platelets have dropped more than 50%, let's say in 5 days. You calculate the 4T score. If the 4T score, let's say, is low, don't do anything, you just stop right there. If they have either intermediate or high probability, discontinue it, start something else, and then get your HIT panel. That's your immunoassays. If they're negative, don't worry about it. If they're positive, if you have the functional assays, you do it. If you don't, just continue your management as if you don't. It's positive in these kind of patients. So that brings me, like I said earlier, remove anything heparin associated in these patients, including the flushes, including the catheters, which contain these as well. And is that enough for these patients? No, it's not just stopping the heparin. You need to give them something else. And why do you have to give them something else? So there is a risk of 5 to 10% every day for them to develop a thrombosis in the next 2 days. An overall 30-day risk of 50% of them developing a clot in these patients if we don't treat them. So that's the reason usually in cases of severe thrombocytopenia with the thrombosis, what we do is we use parenteral anticoagulants. And what are these that we usually use? We have direct thrombin inhibitors and indirect factor Xa inhibitors. So the direct thrombin inhibitors, you have argatroban, you have lepirudin, you have bivalirudin, you have desirudin, and the indirect factor Xa inhibitors, you have the fondaparinux. So usually, we do have guidelines which tell us what exactly to use. This argatroban is what we generally use most commonly in a lot of patients. One thing I want you to remember is argatroban is the only medication that is mainly hepatically clear. So be careful if you have any patients with liver failure or cirrhosis. And the other drugs, be careful if they have any renal impairment, CKD, ESRD. These have to be renally dosed, and this has to be hepatically dosed as well. So can we use DOACs in these patients? Yes, we can. But who gets them? How do we determine that? I'll just go through once I go through the guidelines. So this is a summary of the 2018 ASH guidelines on approaching HIT. So one, do we screen patients for HIT just because they're on heparin? No, we don't. Because the risk of them developing HIT is, as we said, 0.2 to 5%. So unless we think they have those drop in their platelet counts, we don't really screen them for it. And what is the scoring system? As I said earlier, it's the 4T scoring system that is preferable and recommended by these guidelines. And whom do we usually treat? The ones we treat are patients with acute HIT with the thrombosis, or you have isolated HIT as well, but mainly the parenteral anticoagulants, everything come with this acute thrombosis. Discontinue heparin, start a non-heparin anticoagulant. And how do we choose which one? If the patient is critically ill, they have increased bleeding risk, or they have any urgent procedures that you have to take them to, that's when your argatroban or bivalirudin are preferred because the effect of their duration are low. So in case, let's say they're bleeding, you can always hold off on that. In case they have to go to a surgery, you can hold off on that as well. Hepatic dysfunction, avoid argatroban, as I said. This causes hepatic impairment. And then let's say the patient is hemodynamically stable. This is where you can consider using DOACs if needed, or you can consider using the fondaparinux as well. What if the patient has critical thromboembolism, as in our patient that we saw with the digital necrosis, or what if they have like a pulmonary embolism? That's when always remember, go with the IV drugs and over the DOACs. The DOACs are only for milder cases, not for serious cases. And let's say if you can give a DOAC in this patient, they're stable, which one do you prefer? We have Eliquis, we have Xarelto, we have other ones. But the most published articles or studies that are done were actually rivaroxaban, Xarelto, in these patients. And the dosage of Xarelto is usually 15 milligrams BID 3 times a week, followed by 20 milligrams once a day. And do we give platelets to these people? No, we don't give platelets. Do we give vitamin K? No, we don't give vitamin K. And do we usually go put in IVC filters or anything? No, we usually don't. And if it's, let's say, a subacute HIT, not as emergent, that's where your Xarelto comes into picture. What if the patient had HIT in the past and now is coming admitted to the hospital with an MI? Do you give heparin in that case? Preferable is to give the bivalirudin over the heparin in those cases. Let's say the patient has RRT and you have to avoid thrombosis of their dialysis unit, because usually we give heparin whenever they get these dialysis. What do? Avoid heparin in those cases. Argatroban and bivalirudin. What if they have a recent history of HIT in the past 3 months? What do? In those cases, in these patients, it's preferable they wear a bracelet which says that these patients had a HIT in the recent past. Because a lot of times we don't really document these that well, and we end up giving them heparin, and we never know what's going to happen after that. And if, let's say, the hit was more than 3 months, then you don't have to worry about a bracelet. But within 3 months, definitely put that bracelet on, and hopefully it's documented well enough so the risk of them having the hit is pretty high. We avoid these mistakes that we do. I know the risk is low, but sometimes it is life-costing for these patients. And we had 2 patients that I myself saw within this 1 year that I put up as cases right now. This is it, guys, a very brief presentation from my end on HIT. If anyone wants to add any points.
Yeah. So very good presentation, Aswani. So couple of things that I would like to add is you did mention what
You have to go there. There's Zoom people. Sorry about that.
They should be hearing through the audience mic, right?
I'm not sure.
Turn on the mic up there. There's
I was told that we could hear.
All right, so it was a very good presentation. Couple of things that you already brought up was one is a overdiagnosis or misdiagnosis of it that often tends to happen, on the medicine floors. We got to be cautious about it when we are discussing about the diagnosis. Most often times, what I have seen is when we think about it, we discontinue heparin, but we don't put them on anticoagulation. That's one thing. If we are committing to a diagnosis, we got to go completely through. The other thing that you briefly touched on was heparin. What do we do with heparin? I generally put the patient, add it to allergies list, so that if the patient comes to the same facility, they would have it in their allergies so that they won't get it again. Theoretically, there is a risk of hypercoagulability for 90 days after the diagnosis of HIT. That's the reason the duration of anticoagulation is 3 months. So how long should we continue it? If they actually had a DVT, then it's a little longer, depending on the intensity of the DVT. But if it is a regular HIT that we are discharging from hospital, it's 3 months. That's just the duration. So yeah, and you mentioned about DOACs. The reason why they mention any serious situation with HIT is they don't recommend DOACs is there is no data. So there is no randomized controlled trial looking at DOACs when compared to Vivalidin or Argatroban. So that's the reason we just want to make sure that we anticoagulate them. The other major thing is there is no way that we actually check the level of anticoagulation with a DOAC, whereas with Argatroban, you could actually do it with an APTT all the time. So that is one thing. And one previous name for HIT is actually white clot syndrome. Sometimes surgeons do mention that, when they open up the arteries, they see a white clot. They say it's pretty diagnostic from surgeon standpoint. But do you have any other points, Dr. Mills?
No, I think that was covered very well. Platelet factor 4 is an interesting molecule. If you look at the physiology of it, it's in the granules, alpha granules as I recall, and its purpose is to inhibit the effect of heparin, to be prothrombotic. Normally in our bodies, we have heparin proteoglycans on cell surfaces, and that's the heparin that accentuates antithrombin 3. Really, antithrombin 3 is not a very good anticoagulant or blocker or downregulator of coagulation cascade unless heparin is present. And it really accelerates the activity of antithrombin 3. So you have to have a way to downregulate antithrombin. If you downregulate antithrombin 3 activity, you'll promote clotting. So it's another way to promote clotting. Activate the platelets, get them clumping, exposing, they secrete clotting factors. They develop a membrane where clotting can occur on. But also you inhibit the heparin, and that accentuates it. So that's its normal physiologic role. Unfortunately, it's very immunogenic, like you mentioned, and frequently leads to antibodies against this complex. And that's the big problem. When that happens, it can activate the platelet. So the reason it's called white clot is really it's very much activation of platelets. And there's very little red cells trapped in the clot. Normally when you get a clot, you get lots of red cells trapped in it as well, and that's why it's red. All right. So you do, since these antibodies can be persistent, and since heparin is present in the blood vessels, it can cross-react with the antibody. That's why you have to anticoagulate if it's the type 2. I think the most difficult thing for us, as you mentioned, is this a 1 or a 2? Is this the one that's benign, we don't need to do anything about, or is this the one that's going to be really bad and we're just looking at the tip of the iceberg, but there's really trouble brewing. This clotting is going to start any time now. And there's virtually no way to figure that out. It's your clinical judgment. You know, I sort of sometimes look at how rapidly is the count fallen. This type 1 tends to drift down gradually by day 5 and 10, you know, out there, whereas the others tend to be a more precipitous drop. But that's not 100%. So the low molecular weight heparins too, that you know, we use them quite frequently. They are much safer than heparin. The thing to remember is that you do get cross-reactivity with it. And I've seen the errors made where people have hit one time and they say, well, we can use Lovenox or something else later on. You don't want to make that mistake. No, you cannot. Once the chance of getting hit is much reduced with the low molecular weight heparins. But once you have the antibodies, it's going to cross-react with both heparin and low molecular weight heparin. So you cannot use it again. Okay, you got to stay away from it. Yeah. Now, and also fondaparinux is interesting because it is a picosaccharide. It does bind just like heparin to antithrombin 3, but it doesn't have the side chains attached that the antibody reacts with. That's usually why it's safe to use in this setting. As you said, it's the one I prefer to use, but if there are acutely problems going on, then argatroban is easier because it doesn't last as long. So you can get out of trouble quickly if you get into trouble. Bivalirudin, you know, that's got an interesting, you know where that comes from? From leeches, right? That's the anticoagulant in the leech. So it's entirely structurally different than regular heparin. That's why you could use those compounds because they're totally unlike it. Originally, what we'll do is put them on argatroban, and then after things calm down, after a week or two, we'll switch them to cumin. They can be discharged on cumin, or they could be discharged on fondaparinux too. You get them under control with argatroban, shut things down. Once they're stable, put them on fondaparinux because clotting can occur out to 4 to 6 weeks, like you mentioned. They are going to need some anticoagulation. It's a very interesting syndrome, you know, and difficult to handle many times.
Yeah. Dr. Burton mentioned to me one time, like, we do see a lot of hit around the same time of the year. Sometimes they say it's the vials that they use, the pharmacy that make them, or the
Yes.
where our hospital bought it. So it does tend to happen. Apparently there was there are a lot of hits all that heparin was made by a Chinese company or something of that sort.
So
This is a few years ago.
heparin, you know, you think of it as a drug, but it is derived from the bowels of animals, you know, cows, pigs, and you sort of dissolve it out. So if you look at a batch of heparin, it's not a pure product, you know, like, oh, this is a 20-chain amino acid. No. It's, you know, all sorts of different sizes, makeup, and that's why certain batches may be more prone to develop this than other batches. The low molecular weight heparin, you purify it and separate out the higher components so that you make it a better product. It's pure, if you will. but they're not like a classic drug. It's just, a fixed chemical entity.
That's it.
So what could have been going on in this patient's lungs, too, causing a brownish discharge from the lungs? Brownish fluid you described. Right, diffuse alveolar hemorrhage.
Thank you very much once again. And thank you, Dr. Mills, for staying with us and teaching us, and Dr. Gundapalli as well.